Hello everyone. So today we're going to do our lecture on the endocrine system. Now, if you remember from anatomy and physiology, the way the endocrine system operates is thanks to the hypothalamus. That's the major gland that controls its function. The hypothalamus will dictate another gland, the anterior pituitary, and then the anterior pituitary would instruct any endocrine gland to allow it to secrete its hormone. So the types of diseases that we're going to review are going to be either a hyperfunction, when we see excessive secretion of a particular hormone or group of hormones, and hypofunction. As the name suggests, this is when we see the opposite, i.e. only or a decrease in the level of a given hormone. And then we'll review some tumors affiliated with the endocrine system. So the hypo versus hyperfunction. Now, when we see hypersecretion of a particular hormone, as you can predict with any gland in the body, it could be because of a tumor. Remember, tumors are functional in some cases, meaning that because there is an increase or a mutation, then we see an increase in the level of hormone secretion. It could also be because of hyperplasia, increase in the cell number. So instead of having, let's say, an X number of cells secreting a particular hormone, we're going to double or triple these cells, so we end up with excessive secretion. The hyposecretion, on the other hand, could be because of agenesis, meaning that the gland doesn't develop at all. Could be because of atrophy, so when there is basically a decrease in cell size, or a direct destruction to the gland, which we'll see that this is a frequent theme with hyposecretion or hypofunction of endocrine glands, particularly triggered by autoimmune diseases. If you forgot what those are, autoimmune diseases, they're diseases where the immune system damages cells and the tissues within the body in one way or another. So the first gland on our list will be the thyroid gland. We'll start with hyperthyroidism. As the name suggests, it's an increased level of T3 and T4. Those are the two forms of thyroid hormone. T4 is the tetraiodothyronine. Remember, this is the most abundant form of thyroid hormone. And T3, or triiodothyronine, which is the most, or the metabolically active form of thyroid hormone. So this will result in an increase in the metabolic rate of all cells, so the overall metabolism would spike. Clinically, hyperthyroidism will present with increase in cardiac function, so tachycardia, palpitation, and in fact, in medical or clinical settings, any young healthy individual presenting with a palpitation, unexplained palpitation, usually suspect hyperthyroidism. Nervousness, heat intolerance. A lot of people with hyperthyroidism complain that it is too warm even if it's cold. Weakness, tremors, diarrhea because of the increased metabolism or metabolic rate of all GI tract cells. And then weight loss even though they eat and they have good appetite, because the furnace in the body, the metabolism, is extremely high. If we do a test to investigate hyperthyroidism, we'll see elevation in T4 and a decrease in TSH. This is providing that the problem is within the thyroid gland. So meaning that if you go back to what we started, hypothalamus to pituitary to thyroid, if the problem is here and we have an increased level of T4, because of the negative feedback loop to the pituitary, then we'll see a decrease in the level of TSH. Now, if it's secondary, meaning that if the problem doesn't start within the thyroid gland, let's say that this time the excessive thyroid problem is because of the pituitary, so it's a secondary problem. Now, here we'll see an increase in TSH level, and that will result in an increase in T3, T4 levels. So if it's secondary, the TSH will be high because the problem is in the pituitary. If it's primary, meaning that if it's within the thyroid, then the increase in T3, T4 because of the negative feedback loop to the pituitary would decrease TSH. Why does it happen? Well, there are several triggers. It could be adenoma, it could be a goiter, it could be Graves' disease. This is one of the most common forms. It's an autoimmune disease where circulating antibodies will trick the thyroid gland to producing more thyroid hormone, or it could be because of exogenous intake of thyroid hormone through pills. Now, why do people abuse these pills? Because a lot of people, especially if they have access to these pills, will use them as diet aid and weight loss programs. So in terms of symptoms, so we're going to focus here. We see thinning of the hair, bulging eyes, something in clinical setting we call exophthalmos. We see enlargement of the gland itself, not always, but it could happen. The tachycardia, which could predispose to heart failure, weight loss, diarrhea, hyperreflexia, and so on. And of course, the heat intolerance that I've mentioned earlier. The first example on our list will be Graves' disease, which is an autoimmune disease where we have an antibody in form of immunoglobulin G that will basically stimulate TSH receptors. Now, please keep in mind that Graves' disease is one of those interesting diseases simply for the following reason. So far, with every autoimmune disease that we've encountered in this course, the autoantibody can destroy. We said it will destroy a cell, a receptor, it will damage something in the body. Now here, it's a little bit different. The autoantibody, the IgG, instead of it destroying the receptor, it's actually stimulating that receptor. That's why we end up with a state of hyperthyroidism, because this IgG is actually stimulating the thyroid gland rather than damaging it to produce more of the hormone. So it's fairly common in females, as all other autoimmune diseases. We've established that about them. We see hyperthyroidism, we see enlargement, goiter within the gland, we see the bulging of the eye, the exophthalmos, and an inflammatory problem with particularly seen in the leg, the pretibial edema or myxedema. Other notable causes would be a goiter, multinodular goiter, an adenoma. The term toxic, it means it actually causes hyperthyroidism. And Hashimoto's thyroiditis, although this is a common cause for hypothyroidism, but because of the initial, look at the name, itis, inflammation. Because of that initial phase of inflammation, the gland becomes, or the follicles in the gland become too kind of fragile, all right? So the moment they break, they leak all their content, all the thyroid hormone they're storing into the blood. So that's why it's only transient during the very first inflammatory phase of this disease. The term goiter is a term we use to saying enlargement within a gland, within the thyroid gland, fairly common in females, and we see an enlargement and nodularity within the thyroid gland. The Hashimoto's thyroiditis, we said this is a chronic autoimmune disease, but this is kind of the typical autoimmune disease that you expect, which involves destruction of the gland and a subsequent hypothyroidism. Again, let's just remind ourselves that the reason we mentioned it here in hyperthyroidism, although it being a hypothyroidism, is because we said in that initial inflammatory phase, there is excessive hormone, then we go into a state of hypothyroidism. Clinically, fairly common in female because it's an autoimmune disease. It may present with painless enlargement. Now, if we see painful enlargement, this is usually an indication of infection. And we'll talk about another subset. a state of hypothyroidism, and only during the initial inflammatory phase we see a state of hyperthyroidism. The gland itself will be pale, enlarged, and microscopically we see infiltration of lymphocyte. Those are chronic inflammatory cells, if you remember. Neutrophils were the acute inflammatory cells. Lymphocytes were the chronic inflammatory cells. And then changes within the epithelium as well. Now, if you recall in the past when we talked about autoimmune diseases, we said a lot of these patients with any form of autoimmune disease, they become at risk of different sorts of autoimmune diseases. So it is typical that a patient with Hashimoto's would be presented with another sort of an autoimmune disease. And the overall risk of lymphoma would increase in this particular scenario. Now, on the very opposite extreme of that spectrum, we have the hypothyroidism. In hypothyroidism, there is decrease in T3, T4, and kind of the overall metabolism of the body would also go down. Now, clinically, it's the opposite of hyper. We see fatigue, lethargy as opposed to nervousness and tremor, sensitivity to cold temperature. They always say it's cold even when it's warm, kind of the opposite of hyperthyroidism. Cardiac output would decrease as opposed to the tachycardia we've seen. Myxedema, constipation as opposed to the diarrhea, and unovulatory cycles. Clinically, there is a decrease in T4, and if it's a primary problem, meaning that it's within the thyroid gland, then the pituitary will elevate the TSH trying to correct that problem. But if it's secondary problem, meaning that it is within the pituitary gland, then there is decreased TSH, and that decreased TSH will cause a decrease in T4. Now, the most common cause for hypothyroidism is accidental. It's iatrogenic. This is usually caused by someone who has hyperthyroidism. They get radioactive iodine treatment or even surgical treatment, and there is damage to the thyroid gland to the point where now they have less than normal levels of thyroid hormone. So it could be secondary to surgical removal of the thyroid gland, thyroidectomy, or to radioactive iodine treatment, which is given to destroy some of the gland. But sometimes it's too much to the point that we lose a lot of the gland. And the treatment will be to provide to give supplementation of thyroid hormone, something called Synthroid, kind of like saying synthetic thyroid hormone. And that's the one I mentioned earlier that people may abuse for the purpose of weight loss. Now, other causes, congenital causes, would include basically a deficiency in iodine during pregnancy. So babies would fail to thrive. They may have stunted growth, mental problems, development of the brain with seizures, and motor incoordination. Now, usually this is a problem for, let's say, a mom who is hypothyroid, has iodine deficiency, and then gets pregnant. Now, thyroid hormone is an anabolic hormone, so it is required for the normal growth of the baby. If it's deficient for any given reason, then the development of that fetus will kind of be stunted. Clinically speaking, we see in the hypofunction section, so we see the heart failure, the constipation, the cold intolerance, and edema within extremities. Clinically, as you can tell, the symptoms are the exact opposite of hyperfunctioning, and it really all boils down or goes back to the functions, the normal functions of that thyroid hormone. Now, the tumors, the classical scenario, at least for the benign tumors, will be adenomas, Follicular adenomas are fairly common. They are painless, they're solitary, and in some cases they may trigger hyperthyroidism. Carcinomas, the most common form is a papillary carcinoma. It's more common in females. It accounts for the majority of thyroid cancers, over 80%. That's really majority. Now, histologically, we see papillary pattern. Remember papillary, the finger-like projections. And it can spread through lymphatics, usually to the nearest lymph node group, which is in the neck, the cervical lymph nodes. Other types would be things like follicular carcinoma, which can spread through the blood, through the bones. We have medullary carcinomas, which medullary, it means in the medulla, which has all the C cells, which secrete calcitonin. We may see nests of polygonal cells and a lot of amyloid deposition as well. The last type is the anaplastic carcinomas. They are firm, they are bulky masses. Because they're large, they may press on the trachea, causing shortness of breath, dyspnea. They may compress the esophagus and the throat, causing difficulty swallowing, dysphagia, and can invade all the nearby structures like the trachea and the esophagus. All right,